خلصت.
Assalamu alaikum. Hello, everyone, and welcome to Quality Leaders Academy. We all know that healthcare professionals work incredibly hard, but often when errors happens, it is not about a lack of skills, it is about the system working against us. Today, we are here to change the perspectives over the next 60 minutes. We are diving into human factors, engineering, and ergonomics. We will explore how to design our work environments to support safety and efficiency, moving away from blame and toward better design. Guiding us through this journey is our expert speaker, Dr. Nadim Ahmed, Bachelor of Medicine and Surgery, Master degree in Hospital Management, Certified CBHQ and Lean Six Sigma Black Belt, Healthcare Quality and Patient Safety and Accreditation Professional with 12 years of experience. Welcome, Dr. Nadim.
Thank you, Doctor.
Thank you. Let's go.
Right. Assalamu alaikum. Masa al khair. Good evening, everyone. I'm so glad you are all here. Today, we are going to talk about something that affects every single one of us in healthcare. Whether you are a physician, nurse, pharmacist, administrator, quality professional, or any other role, we are going to talk about human factors engineering and ergonomics in healthcare. Now, by the end of this session, I'm hoping that you are going to see your workplace differently. You are going to understand why good people make errors in bad systems. And most importantly, you are going to live with practical tools you can use right away next week. Let me start with a story. It's 2 a.m. The ICU is busy tonight, more admissions than expected, two unstable patients, short staffed because of leaves and call outs. A nurse named Sarah, the night shift nurse, is preparing medications. When we look at her background, she's been an ICU nurse for 8 years. She's good at what she does, dedicated, careful. Actually, the kind of nurse you'd want caring for your family. Now she's on her third 12-hour shift, night shift in a row. She's tired, but she's managing somehow. And at 2 a.m., she receives an order for some medication for a patient. She goes to the medication room, reaches out for the drug from the automated dispensing cabinet, scans it, and prepares to administer it. But she grabbed the wrong medication. The drug names were similar. In fact, that's what we call like look-alike and sound-alike medications, right? And the packaging was nearly identical. The lighting in the room, medication room, was dim, and she had been interrupted twice while preparing it. And the computer interface showing the order was on a different screen from where she was preparing the medication. Now, fortunately, a colleague caught the error before it reached the patient. It was a near miss. But she was devastated. She thought, how could I make such a mistake? And I have done this thousands of times. Now, the hospital conducted an investigation into this near miss incident and concluded nurse failed to properly verify medication before administration. Recommend additional training. But here's the question I want you to think about. Was this really her fault? Or was it the system's fault? Think about it. An experienced, conscientious nurse trying her best, following procedures, yet she still nearly made a critical error. Why? Because the poor lighting made it hard to read labels clearly. The similar drug names and identical packaging set her up to fail. And the fatigue from 3 consecutive night shifts impaired her cognition. We know from research that after 17 hours awake, your brain functions like you have a blood alcohol level of 0.05 percentage. The interruptions disrupted her concentration. Every interruption increases error risk, and the confusing computer interface split her attention. Now, let me ask again, who made the error? The nurse or the system that set her up to fail? So, this is what human factors engineering is all about. Today, we are going to explore 5 key areas together. First, what exactly is human factors engineering and why should you care? And I'll try my best to explain it in plain English so that you all can understand. And second, how do our human limitations, our totally normal biological human limitations, create risk in healthcare? And more importantly, why it's okay that we have these limitations. And number 3, we'll look at real examples of systems that work with humans and not against them. Success from healthcare and other industries that we can learn from will be discussed. And fourth, I'll give you simple practical changes you can implement immediately next week at your own workplace. And finally, we'll talk about how you can protect both your patients and yourself through better design. It's all about safety for the patients as well as for healthcare staff. Now, this isn't a theory for theory's sake. This is about making your work life better and your patients safer. Ready? So let's move. Here, what is human factors engineering? On top left, you see the definition given by International Ergonomics Association. I'll read it once. Ergonomics or human factors is a scientific discipline concerned with the understanding of interactions among humans and other elements of a system and profession that applies theoretical principles, data, and methods to design in order to optimize human well-being and overall system performance. Well, if that's confusing, let me make it easier for you. Let me give you the simplest definition that I can actually tell in order for you to understand. Human factors engineering, in simpler terms, is designing equipment, tasks, and workplaces to fit people, not forcing people to adapt to bad design. That's it. That's the core idea. Now, think about your smartphone for a second. You all use smartphones, right? So, when you got a new smartphone, did you happen to read a 200-page manual or a sort of guide on how to use that smartphone? Probably not, because the user interface and icons made sense for you. Swiping was natural and everything, the interface was intuitive, because that's good human factors design. Now think about the medical devices that you use at your workplace. If you're a nurse or a doctor, think about the medical devices that we handle and come across at our hospitals. Yeah, not quite the same experience, right? So here's what the difference is. So we are supposed to design the equipment, tasks, and workplaces to fit people and not force people to adapt to bad design. So you might hear different terms for the same concept. Some people call it human factors engineering, others call it ergonomics. And no, ergonomics isn't just about comfortable chairs, though that's part of it. You might hear human centered design or systems approach to safety. So, all of these terms describe the same basic idea: design systems, equipment, and processes to match how humans actually work, not how we wish they worked or how they theoretically should work. Now, here's the uncomfortable truth. And I'm not sharing this to make anyone feel bad, but because we need to understand the scope of the problem, and every one of us are from the healthcare background. In some countries, medical errors are the third leading cause of death. Think about that for a moment. Not the disease itself, but preventable errors in how we treat the disease. Research, I mean, like the reference is there at the bottom. Research shows that 1 in 20 hospital patients is harmed by a preventable error. 1 in 20. If in case if that was a infection rate, if one patient out of every 20 patients were getting some sort of hospital acquired infection, then definitely there would have been a crisis team convened by the hospital authorities, all the RCS being done and all. But here, 1 in 20 hospital patients were harmed by preventable errors. And here, there's another statistic. A study from Taiwan found that 63.8% of medication related adverse events involve what was labeled as human error. But, and this is crucial, most of these human errors are actually system failures and not people failures. Like in our story, when a good nurse with 8 years of experience nearly gives the wrong medication, that's not a people problem, that's a design problem. And we know we can do better because other industries have solved this exact problem. Let me tell you about aviation. In 1960s and 70s, plane crashes were relatively common. And you know what everyone did? They blamed the pilots. Pilot error was the conclusion in accident after accident. But then something changed. Aviation started applying human factors engineering principles. They redesigned cockpits. They created standardized procedures and checklists. They developed crew resource management training that taught teams to communicate better. They built systems that caught errors before disasters happened. In all this, do you think they got better pilots? No, they got better systems. And you know what? Today, this is one of the things which I usually take up when I speak about the safety and all. Commercial aviation is extraordinarily safe. In fact, it is said that you are more likely to be injured driving to the airport than on the flight itself. So that statement itself tells you how aviation, or in a way like travel by air, is much safer when compared to other modalities. And this has been possible only because the industry has applied human factors engineering, and they got better systems. So here's the exciting part. What if we did the same thing in healthcare? What if we designed medication systems that prevented errors instead of relying on exhausted humans to catch every mistake? What if we created workflows that reduced fatigue instead of expecting people to function well after 17 hours of work? Or what if we built equipment that was intuitive to use instead of requiring extensive training to perform basic functions? What if we organize work in ways that supported caregivers instead of creating constant obstacles? This isn't about changing people, it's about changing systems. After this session, even if you remember nothing else from this lecture, that's fine, absolutely fine. But remember these two core principles. First, to err is human. Humans will make mistakes. Our brains have built in limitations. We can only pay attention to so much. Our memories fail us. We get fatigued. We see what we expect to see, not always what's actually there. And you know what? That's okay because that's not a moral failing. That's just biology. That's how brains work. This is the same brain that can perform complex surgery or diagnose rare conditions. And it's the same brain that can forget to do something you absolutely intended to do. Both are simultaneously true. And second principle is systems can reduce harm. Now read that again. Systems can reduce harm. Good design catches errors before they reach patients, whereas bad design creates errors even in excellent clinicians. So here's the important part. We control the design. Therefore, we control the safety outcomes. So why does this matter to you specifically? Because I hope everyone is from the healthcare background, because you work in these systems every single day. You experience the design flaws directly. You know which equipment is confusing, you know which workflows create bottlenecks, you know where interruptions constantly happen, and you can identify problems that people sitting in offices might never see. You are on the ground. You can advocate for better design. You can implement changes in your own area. You can protect yourself and your patients. As far as the patient safety and quality professionals are concerned, on the ground, you can make the difference. You're not just here to listen to this abstract, boring theory, but to learn certain insights and apply these tools at your workplace. So, let's talk about humans. Specifically, let's talk about how our brains actually work with all our beautiful limitations. I say beautiful because these limitations are not flaws, they are the features that helped our ancestors survive. Our brains evolved to keep us alive in the African savannah, but not to manage 50 patients in an ICU throughout the evolution in a way. So, understanding our limitations is the first step to designing systems that work with them and not against them, right? So, these are the limitations: attention, fatigue, memory, and pattern recognition. So, let's start with the first limitation, that is attention. And here's the thing: we cannot focus on everything at once. It's not practically possible. Our brains use what's called as selective attention. We are constantly filtering information, deciding what to focus on, what to ignore. So this is actually useful. If you paid attention to every sound, every movement, every sensation, you would be very much overwhelmed and unable to function at all. Now I'm trying to speak to you. I'm trying to be on Zoom call, talking about this particular topic. And if at all I am supposed to hear every movement or every sort of sound that comes in my way around me that's present now, it will be very difficult for me to perform the simple function, right? I hope you got it. But it means we sometimes miss important things also. I mean, like, have you ever looked for your car keys when you were going out? Uh, and they were just right in front of you. That happened to most of us, right? That's inattentional blindness. I mean, like, there's a famous psychology experiment where people were asked to count basketball passes in a game, and you know what, they completely missed out someone in a gorilla suit walking through that scene. Out of that experiment, it was told that we see what we are looking for, we miss what we are not expecting. So, coming to divided attention, multitasking, and research is very clear regarding this. When we split attention between tasks, performance on both the task decreases. You might think you are good at multitasking. You say, I'm a multitasker. Probably you're not. None of us are. Our brains just are not wired that way. So we'll have to understand the limitations that we have, the limitation of attention. Now, memory is another beautiful limitation. Our working memory, the mental workspace where we actively think, can only hold about 7 pieces of information at once, plus or minus 2. That's it. Now, coming to prospective memory, what's prospective memory? Remembering to do something in the future, but it fails us constantly. How many times have you walked into a room and forgotten why you went there? Or said, okay, I'll do that work as soon as I finish this, and then completely forgot about that? Many a times. And here's the scary part, our brains also create false memories. We remember things that didn't happen or remember them differently than they have occurred. Multiple studies confirm this. Our memories are reconstructions, not recordings. So when someone says, I'm sure I have checked that, they probably genuinely believe they did. Their brain might have filled in that memory. This isn't lying. They weren't lying. But this is how human memory works. Now, coming to limitation number 3, fatigue. Oh boy. Talking about fatigue in healthcare, probably this is where most of us might be, in a way, like thinking, yeah, this is what I have gone through, right? Here's what the research tells us. After 17 hours of being awake, your cognitive performance is equivalent to having a blood alcohol level of 0.05 percentage, which means in many countries that's legally what do you say, not allowed to drive. The blood alcohol percentage of 0.05 percentage is illegal to drive in many countries, and our brains perform as if we have we are under the influence of alcohol after 17 hours of being awake, right? And extended shifts double the error rates. I mean, like, this is not slightly increased, they double them. And night shifts disrupt the circadian rhythm of our body's internal clock, circadian rhythm, circadian clock, right? Even if you sleep the same number of hours during the day, night shift workers never fully adapt, because your body knows you are supposed to be asleep at 3 a.m. and not working. And fatigue affects everything: judgment, attention, reaction time, communication, compassion. When you're exhausted, you know you are not performing at your best. But here's the tricky part. Fatigue also it impairs your ability to recognize how impaired you are. So that's much sort of a dangerous thing. When you are tired, but you are unable to understand how tired you are, that's dangerous when you are working in healthcare, when you are taking care of the patients and all. And in a way, like, we have the actual data on fatigue. In Pennsylvania, their patient safety reporting system documented more than 1,500 fatigue related events. Most were caught before reaching the patients, but some weren't. And 4 out of those events resulted in patient deaths. Let that sink in. 4 deaths purely because of healthcare workers' fatigue. And we are talking only about the ones which were reported and recognized as fatigue related. Now, just imagine and think how many others were not reported or were not identified as being caused by exhaustion and fatigue, right? Now, coming to the fourth limitation, that is pattern recognition. We see what we expect to see. In a way, like our brains are incredible pattern recognition machines. This usually helps us. It's how you look at a patient and think, okay, something's not right here, even before you actually can articulate what's wrong. That's a sort of subconscious sort of mind and recognizing certain patterns, but it also creates certain biases. Okay, confirmation bias means we seek information that confirms what we already believe. Okay, this is confirmation bias. Anchoring bias means we fixate on our first impression and have trouble changing our minds. And availability bias means that recent events seem more likely than they actually are. I hope you got the point. Confirmation bias, anchoring bias, and availability bias. This is why similar medication names cause so many mix ups, because your brain sees the first few letters, fill in the pattern based on what's common, and you read what you are expected to see, not what's actually there. So that dopamine, in a way, like your brain sees GOP and fills in amine, and you have already reached for the wrong drug before your conscious mind catches up. So this is how the pattern recognition works. In a way, like this is how our brains function, and this was the fourth of the limitations. Now, here's the good news regarding these limitations. All these limitations are predictable. I mean, like, if you know attention has limits, we can design systems that don't overload attention. We can reduce distractions. We can make important information stand out. If we know memory fails, we can build in reminders. We can create forcing functions that won't let you proceed until you have completed a critical step, like in checklists. Okay, so if you know fatigue impairs your performance, we can manage work schedules better. We can create systems where that are fatigue resistance. We can implement certain napping policies and adequate break rooms for extended shifts and all. If you know biases exist, we can create visual differentiation. We can add verification steps. We can use technology to catch common mistakes. Once you understand the problem, you can actually engineer the solutions. That's what human factors engineering does. We don't try to fix humans, we fix the systems humans work in. I hope you got the point. Now, let me introduce to you a framework that makes all of this practical. It's called the SEIPS model, SEIPS model, which stands for Systems Engineering Initiative for Patient Safety. So look at the model. Here on the screen, we are having a SEIPS 101 simplified model. This is a simplified version of it. But the core idea is the same. At the center, you have the person, the healthcare worker or the patient, but that person doesn't work in isolation. No one can, you can't work alone. Right. So the person works in a system made up of elements, 5 elements: tasks, which work needs to be done, how complex is it, what's the workload, then tools and technology, which include equipments you use like medical devices, computers, simple tools. Even if they are well designed or poorly designed. And then comes environment, the physical space that you work in, the lighting, noise, the layout of the room, the temperature. Is an environment supporting you or is against you? And then organization, the policies of the hospital or the organization, the culture, staffing levels, like the time pressure. Like the organization is a soft stuff that has a very much hard impact, right? And all these elements interact with each other and with the person in the middle. And here, if you change one element, you change the outcome. And this SEIPS model is based on Donabedian's SPO model, structure, process, and outcome. That's modified in a way to include all the possible structures working together. Okay. So let me make this more easier by having an example for you. Now think about the medication administration. So here, during the process of medication administration, the person is the nurse, right? Now, the factors which we are supposed to take in are, is the nurse experienced or new? These are the factors, because these are the elements which actually impact the outcome, right? Are they well rested or are tired? Do they have good vision, or any personal factors affecting the performance of that particular nurse, right? Now, coming to the tasks regarding the medication administration, they need to verify the patient identity, retrieve the medication, calculate the dose, check for allergies, verify the order, prepare the medication, administer it, and then finally document it. Lots of tasks, each with, again, steps and few other things. Now, coming to the tools for medication administration, there's a medication cart, there's a barcode scanner that might or might not work. Then there's IV pump with confusing buttons, computer system with the order. Each tool may either help or hinder. Now, coming finally to the environment and organization. Environment is, is the medication room well lit? The lighting, the noise, are there constant interruptions? Is equipment within easy reach? Or is the nurse stretching herself? And finally, the organization. What's the nurse patient ratio on that particular shift? Is there any time pressure? Or is the culture within the organization comfortable for people to ask for help? Are there any protocols for double checking high risk medications? See how all these elements are interconnected. Change the staffing ratio and you change the time pressure, which then again affects the attention, which affects the error rates. Once you improve the lighting, you also improve the accuracy. When you reduce interruptions, you reduce cognitive load. Here, everything is connected. And this is systems thinking. Speaking of the systems thinking, let me show you two different ways of approaching errors. The old way is the linear thinking. It goes like this. When an error happens, find the person who made the error, blame that person, retrain that person, maybe discipline them also. Problem solved, right? Wrong. Because next month, someone else will make the same error. So you keep on retraining them and the cycle continues. So this is an old way of linear thinking. Now coming to the new way of systems thinking, it goes like this. When an error happens, analyze the system that allowed the error and then fix the design. Now, the error after fixing the design is much less likely to happen again, regardless of who's working. Here, of course, the training is supposed to be given, but once you fix the design, whoever it may be, they will adapt and the errors are likely to reduce. There's a beautiful quote from Paul Batalden. He's a quality improvement expert, where he says, every system is perfectly designed to get the results it gets. I'll read that again slowly. Every system is perfectly designed to get the results it gets. If your system is producing errors, it's because your system is designed, even if unintentionally, to produce those errors. If you want different results, change the system's design, right? Now, let me show you one more foundational concept. It's called the Swiss cheese model, developed by James Reason. Here, there are several slices of Swiss cheese lined up. Each slice represents a layer of defense in your system: organizational factors, supervision, preconditions, and the actual moment of an unsafe act. Each slice has holes. Holes represent the weaknesses in that particular layer. Usually, what happens is the holes don't line up. So, even if there's weakness in one particular layer, the next layer catches it. But occasionally, what happens is all the holes line up. And this is when accident or any sort of incidents happen. The organizational layer fails, the supervisory layer fails, the preconditions were wrong, and the person at the sharp end made an error. Boom, the arrow goes straight through all these holes and causes harm to the patient. It's never just one failure. Remember, it's multiple failures lining up. So when we investigate errors, we shouldn't just ask like who made the error, who made the mistake. We should ask how did all the defenses fail simultaneously, and how do we add more layers of defenses, or how to make the holes smaller. This is what our thinking for the systems, for the benefit of the system should be. Whenever an incident happens, this is how we are supposed to adapt. Right, now let's talk about some real world consequences when we ignore human factors. I mean, like, we are not talking about any hypothetical scenarios. We are talking about the documented cases with real impacts. Okay. A researcher named Kim Vincent designed, or in a way, like, sorry, studied the PCA pumps. I mean, like, patient controlled analgesia pumps. And in his study, he found that design flaws in the interface, in the interface of those pumps, led to programming errors that caused medication overdoses. So here, the real patients were harmed. And lookalike, soundalike medications, cause thousands of errors around the world, in thousands. And if you're working in an ICU, you will definitely know this, that alarm fatigue in ICUs is real. You know this one. Studies shows that 99% of alarms are false positives or clinically irrelevant. So what happens is staff becomes desensitized to all these alarms. And then when a critical alarm gets missed, then the error happens. And finally, when coming to the healthcare worker fatigue, we mentioned this earlier, but I'm trying to repeat. Pennsylvania's reporting system documented almost 1,600, more than 1,500 fatigue-related patient safety events, including 4 deaths. And again, we are talking about what were reported only. Okay. So let me take you through how one design flaw can actually lead to another and finally to a disaster. It starts with the design. Two medications having similar names. Imagine this. Two medications having similar names and nearly identical packaging. And that's what we call as the first hole in the Swiss cheese model. That creates attention problem, because under time pressure, what happens is these visual similarities, it's easy to grab the wrong one when they are similar. When Lassa drugs are together, it's very easy to grab the wrong one, right? And now comes the third, memory failure. The nurse gets interrupted mid-task. When she returns, she has to remember where she was in the process. But when her prospective memory fails, then there's another layer of hole, another sort of failure. Now coming to the layer in environment. The medication room has poor lighting, making it harder to read small print labels, and mix-in fatigue. I mean, like, this might be the 11th hour of the 12-hour night shift where cognitive function is impaired, and that results in an error. Wrong drug is selected. But wait, we are not done yet. There should be another defense, right? That is independent double check. In all our systems, we do have these particular things. for whether maybe for high alert medications or for last side medications or whatever it may be. Finally, we do have this system defense of independent double check by another nurse. But if that system failure happens, if the second nurse is also rushed, is also fatigued, and is subject to the same design flaws, what happens? It finally leads to patient harm. See how one thing leads to the other. It's not just one thing, it's multiple system failures aligning all together in a line. I hope you got it. How the systems fail and how the practical implementation or the practical thing about the Swiss cheese model is. And now let's talk a little deeper regarding the fatigue, because this one really matters and it's something we can actually do something about. I mentioned earlier regarding the Pennsylvania's data, and let me break it down. 1613 reported fatigue, like like reported fatigue related events, and 80% were near misses which were caught before reaching the patients. Well and good. And 18% were incidents where patient was affected but with minor harm, and 2.3% were serious events with significant patient harm, and finally 4 deaths which were directly attributed to healthcare worker fatigue. Now imagine 4 families who lost someone they loved because a system forced healthcare workers to function, to work beyond their human capacity. And here's the question we need to ask: how many events were not reported? Because how many times did someone make an error, did not realize it because they were exhausted and just felt terrible about themselves? All these things happen. You see it, I see it, most of us see in our workplaces, right? Because fatigue is the silent killer, and we definitely want to focus on this particular attribute. Now, what does fatigue actually do to our brains? Right? It reduces the attention and vigilance. You know that feeling when you're reading the same line in the chart 3 times, and the words are not processing in your mind, because that's fatigue. Fatigue impairs decision making, and what happens is the tired brains take mental shortcuts, they miss subtle clues, and they make choices they would have never made when well rested. Fatigue slows reaction times, where in cases of emergencies every second matters. Fatigue increases medication errors, and study after study confirms this. It decreases communication quality. Now imagine when you are tired and fatigued, when you are exhausted, how do you communicate with your fellow colleagues? Oh, you become short tempered sometimes. You don't communicate clearly, you mishear things, and obviously it kills compassion and teamwork, right? There was a study wherein the healthcare workers were interviewed regarding the fatigue, and one of the staff quote staff said, we are not only risking patient safety but staff retention. We risk good people leaving because they are exhausted. Here the system has failed them. The good people left the system because that did not help, that did not look after their well-being, that did not what do you say, address the problem of overwork and the fatigue. Okay, so it's very tough to hear, but most of the times this goes unheard in healthcare. We are losing good people to broken systems actually. Now let's talk about alarm fatigue, because this is a perfect example where technology that's supposed to help us is actually creating the risk. Now, in any typical ICU, you see each patient generates somewhere around 150 to 400 alarms per day. Per day. Think about that for a second. And research shows that almost 85 to 99% of those alarms are false positives or clinically irrelevant. That might be because the patient moved their arm and the pulse oximeter might have slipped. The blood pressure cuff wasn't positioned quite right. A lid came loose. So what happens? Of this constant buzzing of the alarm, staff become desensitized. They have to, or if not, they'll go crazy. The alarms become background noise in an ICU. And most of the times when I call my wife from the ICU, I mean, like, she can easily identify because of this all constant buzzing of the alarms. But here's the scary part. When a real alarm happens, when a real emergency comes, when, I mean, like, see, because of all these false positive alarms, the staff gets desensitized. When the actual real harm happens, that gets buried in the noise. I mean, like, more alarms is not equal to more safety. Often they equal less safety. So this is why aviation industry has redesigned their alarm systems many years ago. They have integrated all alarms, prioritized them, filtered out the irrelevant ones, and healthcare is just starting to do this now. Now, when we talk about the design, the equipment, the tools, like we've already talked about the IV pumps or the drug dispensing units, like IV pumps with confusing menu systems. You know the ones I'm talking about. You press a button, expect one thing, and something completely different happens, or it takes several times to press to do what we are supposed to get. Or think about laboratory equipment where multiple buttons look identical. So selecting the wrong test is actually easy, right? Patients monitor. We have patient monitors of several brands, several manufacturers in our ICUs, and each with a different layout, different alarm sound, different ways of silencing alarm. So when you work with multiple types, you have to remember different systems. And coming to medical records, electronic medical records, that might require tens of clicks of what used to take one. So what happens is the doctors and the clinicians develop workarounds and shortcuts, which then create new risks. These are not minor sort of inconveniences or annoyances. These are design failures that waste time, increase cognitive load, and create opportunities for errors. Now, physical environment matters more than most people realize. There are good designs as well as bad designs. How do good designs look like? It does have adequate lighting so you can actually read medication labels, minimal noise and interruptions so you can concentrate, equipment within easy reach so you're not constantly searching or stretching yourselves, clear sightlines for patients so you can see if something's wrong, comfortable workstation ergonomics so you're not developing that chronic back pain. And how does a bad design look? It looks like with dim lighting that causes reading errors, high noise levels causing constant distraction, supplies stored far away from where they are used, so staff waste time searching for it, cramped up spaces, then poorly placed monitors, so you can't see patients while you document, and all. So these are the basic differences between a good design and a bad design. Before we move on, I want to talk about the human cost of poor human factors design. This is something which most of us are willing to talk about also. I mean, this is a constant sort of complaints that we raise because and these are not just statistics and case studies. These are actually the real impacts on real people. For healthcare workers like us, the injuries from poor ergonomics or natural, nurses with chronic back pain from equipment that forces awkward lifting sometimes, and the technicians with repeated strain injuries from poorly designed workstations. And then comes the moral distress from errors within the broken system. That feeling when you know that something could go wrong, you have reported it, but nothing changes, and then it does go wrong. Imagine the situation. I mean, like, a few of you might have faced this. That's the moral distress. And then burnout from working in poorly designed environments. It's working hard against the system that fights you at every step. Okay, there's guilt over errors that were not truly your fault. Remember the nurse of the opening story that we spoke about. She felt terrible, but it wasn't her fault. The system set her up to fail, right? And coming to the patients, preventable adverse events, extended hospital stays, additional suffering, and finally the loss of trust in healthcare. These are all at stakes, and this is why human factors engineering actually matters. Now, there are solutions. The good news is solutions exist and they actually work. These are not theoretical ones. These are measured outcomes from actual interventions. The success stories which I have listed are published. Medication error reduction from 40 to 73% in various studies is documented. That's not a small improvement, that's transformative improvement. There's reduction in surgical errors. In one study, 55% of ergonomically designed surgical equipment has reduced surgical errors. Okay. And in some facilities, there were 10-fold decrease in alarm volume while actually improving alarm quality. 10 times fewer alarms, right? Imagine that. Now, regarding task completion time, 5.5% improvement in the task completion time, 5.5% faster. So these are measured and published results. Okay. Let's look at specific solutions starting with medication systems. Okay. So Tallman lettering. I mean, like most of us have already implemented this in our work systems, wherein dopamine and dopamine uh, are written in the capitals. DOP and DOBUT, the capitals highlight the difference between dopamine and dopamine. It's simple, but it works. Tallman lettering, as far as the medication identification is concerned. And then there's color coding and visual differentiation also, wherein we use that in lookalike medications. And then medication barcode administration, when implemented well. I mean, like here, implemented well is the key. It catches errors before they reach the patient. And then there are standardized concentration guidelines, because if the standardized concentration guidelines are present, you are not supposed to do the complex calculations at 3 o'clock when you're 3 o'clock in the morning when your brain is exhausted. Okay. Automatic dispensing with decision support, if the computer does the math for you and flags potential problems, if at all any. And the dedicated medication preparation areas with strict do not interrupt protocols, because interruptions are a major cause of medication errors. Creating the spaces where you can't be interrupted is a solution, right? So what are the results? Errors decreased, staff confidence increased. It's a win-win situation. Now here's an interesting story. When the National Rehabilitation Hospital in Ireland planned the new facility, they did something smart. Instead of just drawing blueprints and hoping for the best, they built full scale mock ups of patient rooms, complete with bathroom, equipment, everything. Then they spent 6 months having actual staff and actual patients test the designs. They tried different bathroom layouts, different equipment placements, different workflows, and finally they discovered things that never would have appeared on paper, like how the toilet placed 3 inches to the left made it possible for a caregiver to assist a patient safely, or how a certain layout created awkward bending that would lead to staff injuries over time. The final design eliminated all those awkward things. It increased patient independence. Patients could do more for themselves, and it created a comfortable, safe workspace for staff. And here's the interesting part. Getting it right in the design phase cost a fraction of what it would have cost to retrofit after construction. The cost of the design phase interventions were far, far, far less when compared to interventions when done on a later date. Now let's talk about what healthcare has learned from aviations. Starting with the simplest tool imaginable, that is checklist. In aviation, there are mandatory checklists for every phase of flight: before takeoff, before landing, emergency procedures, everything. And here's what important. Even the most experienced pilots use them every single time. It's not like a crutch for beginners, it's a tool for reliability. Okay. The culture in aviation supports checklist use. Nobody says, like, do you need a checklist? Do you know how to fly? That is an absurd sort of question there. Healthcare adopted this with WHO surgical safety checklist. It's a simple list. You all know. Verify patient identity, verify procedure site, check allergies, confirm all equipment present, all that. And what are the results? Surgical deaths decreased by 47% and complications decreased by 36%. Now think about that. A single simple checklist, not an expensive technology, not years of additional training. A single checklist reduced deaths by nearly half. It's not about memory, it's about reliability. Checklist ensures that even when you are tired, even when you are distracted, the critical steps are supposed to be get done. Now, aviation also taught us about teamwork. It's called crew resource management or CRM. In aviation, CRM includes clear communication protocols so everyone knows what everyone else is doing. There's a flattened hierarchy in aviation where a junior crew member can and should speak up if something seems wrong. The situational awareness regarding what's happening with the whole system and not just the little piece of that's in front of you. Then workload management and decision making under pressure. Healthcare adapted this. We have team steps programs, that is strategies and tools to enhance performance and patient safety. Team steps is developed by Department of Defense and AHRQ, that is Agency for Healthcare Research and Quality. We have structured handoff using tools like SBAR, situation background assessment recommendation. And we have psychological safety where staff feels safe speaking up, because both in aviation and healthcare, we have had disasters where someone saw the problem but didn't feel empowered to say something. And we have debriefing after critical events, not to blame, but to learn. Now, we spoke about alarm fatigue, right? Here's how human factors engineering is solving it. The old approach where each alarm device alarm is independent. The IV pump has its alarm, cardiac monitor has its alarm, ventilator has its alarm, and as a result, somewhere around 150 to 400 alarms per day per patient, where 99% are irrelevant. Staff gets overwhelmed and desensitized to all these alarms. The new HFE approach, that is human factors engineering approach, is we have networked devices. All this equipment for each patient gets connected into an integrated system where comprehensive alarm management looks at all the patient's data together. So with smart prioritization, it determines what's actually urgent. And intuitive visual displays show informations in ways that real doctors think. As a result, what happens is 90% of reduction in alarm volume with 100% increasing meaningful alerts. This is not a trade-off. That's just better result. Aviation figured this out decades ago. When they had the same problem with cockpit alarms, they integrated the systems, and now the healthcare is finally doing the same. Aviation also developed fatigue risk management system or FRMS. This is more sophisticated than just saying like don't work more than X hours or Y hours. FRMS includes multiple components. Education about fatigue science, understanding what fatigue does and how it affects the performance. Evidence-based scheduling, knowing that 12-hour night shifts, 5 in a row, will impair performance, designing schedules that respect circadian biology, monitoring to identify fatigue risk proactively, not waiting until someone makes an error. And there's non-punitive reporting system where staff can say I'm too fatigued or too tired to work safely without the fear of punishment. This is one of the key factors as far as the patient safety is concerned. Then mitigation strategies like napping, actually building nap rooms, or with adequate break areas to balance the workload management. And then evaluation of tracking the fatigue related events to understand the patterns. I mean, like, FRMS is not just limiting hours, though it's part of it, it's managing the underlying biology. So let's talk about health information technology, because this is an area where HFE is desperately needed. A good HFE design in healthcare IT looks like clinical decision support that appears at the point of care exactly when you need it. Integrated patient information, not scattered across different systems. Good interfaces with common tasks requiring minimal clicks, smart defaults where the safe choice is the easy choice, visual cues, forcing functions to prevent dangerous orders, all this. And when it comes to bad design, excessive alerts where everyone ignores, requiring workarounds because official procedure is too cumbersome, shortcuts, slowing down workflow so that active staff, staff actively avoid using the system. Remember this, if staff are creating workarounds, that's not staff being difficult. That's like staff telling you that the system design is broken. Listen to them. Now, coming to the physical environmental redesign. So, we have already discussed this. The lighting, adequate lighting at important areas, circadian lights for night shifts, like using blue enriched light to support alertness, good overall illumination for accurate clinical assessments, and good layout supplies at the point of use, not somewhere else. Clear sightlines to patients, adequate space for movement. Okay, and coming to noise, acoustic design to reduce ambient noise, quiet zones for concentration intensive tasks. We've already discussed regarding the Irish Rehabilitation Hospital, right? Good spatial planning actually benefits both the patients and staff. And here's the key principle: involve the users in the design process. Who knows the work better? The people who actually do the work every day know the works better. Here, the participatory design process, in participatory design process, first, observe actual work, not the official procedure, not how you think it's done. Watch what actually happens, including workarounds, shortcuts, and all. Second, interview the frontline staff and patients. Ask about their pain points, frustrations, what makes their work harder. And third, identify specific problems to solve. Next, co-design solutions together. Don't design for them, design with them. And then test the prototype with the users in real conditions. And then sixth, iterate based on feedback. First design is rarely perfect. Take the feedback, redesign it if necessary. Okay. And finally, implement and monitor. This process takes more time upfront, but it results in solutions that actually work because they are designed by and for the people who are going to use them. Okay. Now, you might be thinking, this all sounds good, but I can't rebuild my entire hospital. Yes, fair point. Let's talk about what you actually can do at different time scales. Now, when we look at quick wins, which can be done in days and weeks, look at the improvement of lighting, um, reducing interruptions by adding simple signages or protocols, implementing visual cues, standardized equipment placement, layouts, and all this. And when coming to medium changes which require months, redesign workflows through process mapping and testing, introduce checklists and standard operating protocols, team training in communication and teamwork, upgrade the most confusing or dangerous equipment. Okay. And as far as the long term changes are concerned, which may take years, that includes physical space redesign during renovations, integrated technology systems, cultural transformation around safety and systems thinking, and organizational restructuring to support safety. Start where you are, do what you can. Okay, build success and spread it. Let's address the elephant in the room. We can't afford this. This is what you are going to hear from your leaders in case if you are going to convince them regarding the redesigning. Let us look at costs and benefits honestly. Coming to the costs, yes, there's upfront investment in design or redesign. Okay, staff time for participatory process, new equipment or modification, training and implementation, and all these are costs. But look at the benefits: reduced errors and adverse events. Each serious adverse event can cost you tens of thousands to manage, and I'm not even mentioning the human cost. Benefits include decreased staff injuries and turnover, where replacing a nurse costs thousands, right? And then there's improved efficiency and throughput. Time saved adds up. Better patient outcomes, which improves their reputation and reduces your liability. Lower liability costs and malpractice premiums. And then higher staff and patient satisfaction. See, you can pay now for good design or pay later for the consequences of bad design. And paying later also includes the human cost of preventable harm. Remember that. What do you want to pay? And now you are convinced that human factors engineering does matter. Good. Where do you actually start? Here's a simple assessment toolkit that you can use next week. Ask these questions about your workplace. Where do errors happen most? Look at your incident reports, but also ask staff informally. Where do near misses occur? Where do staff create workarounds? Because shortcuts are like breadcrumbs leading to design problems. If people consistently work around the official processes, use shortcuts, then think that the official process is broken. Ask which equipment do people struggle with. Ask like what devices frustrate you most. I'll guarantee that you are going to get answers for all this. And then ask what causes frustration in their daily work, what makes their job harder, what keeps interrupting their workflow. Chart it for the day. I mean, like, see, start with observations. Do not assume, okay? Don't assume you know what the problems are. Watch, act, and listen. Here's the most systematic approach using the SEEPS model we have learned earlier. Walk through your unit, your ward, or whatever it is. For each area, ask the person factors like, are people getting enough adequate rest? Are they getting right training? Are there individual factors affecting their performance? And then look at the tasks like, are the procedures clear and logical? Is their workload reasonable? Are they trying to do too many things at once or something like that? And then look at tool factors like, is the equipment intuitive and easy to use? Is it available when and where needed? Does it work reliably? And then talk about environmental factors. Is the lighting adequate? Is the layout efficient? And then coming to the organizational factors, and analyze, does the culture support safety in your organization? Are these adequate staffing levels? Is the nurse patient ratio good? Is there any sort of time pressure which is forcing these people to take shortcuts? Document what you find and you will see patterns emerging. And how to prioritize? You can't fix everything at once. Nobody can. So how do you prioritize? Use this simple 2 by 2 matrix here. Okay. High impact and easy to implement things are supposed to be done first. These are your quick wins. High impact, but hard to implement. Then plan carefully. These are important, but need resources and some time and buy-in also. Low impact, but easy to implement. These are nice to have quick wins when you have spare time. And if it is under low impact and hard to implement, deprioritize. Life's too short and resources are too limited. Okay. When we take examples like improving medication room lighting is usually high impact and relatively easy. When we think of new equipment across the hospital, it's high impact, but it is hard. Okay. And then rearranging a supply closet, it's like low impact, but easy one. In case if you're thinking about redesigning your entire electronic medical records system, then good luck. I'm not going to talk about it also. Focus your energy where you are going to get the most of the returns. Okay. Now, here's the hard truth. You can have perfect design, but if your culture doesn't support safety, it doesn't work. What does a good safety culture look like? Psychological safety, where patients or the people can report problems without fear. If your staff are afraid to speak up, you will never identify hazards until they cause harm. Always have non-punitive sort of policy for reporting. Systems thinking should be there and not the blame culture. When errors happen, ask how did the system allow this instead of who did this. Then I mean, like learning orientation where errors are opportunities to improve. Think about that these errors are opportunities to improve. Do not punish them. And the people doing the work know where the problems are. Listen to them. And safety is not just a lip service. Remember this. It needs actual resources like time, money, staff, and attention. And if your leadership support is not there, if the leadership is not visible and consistent, and if the leadership says safety matters but reward speed and cost cutting, then I'm sorry, that's the obvious one. The staff will follow what is being done, not said. Okay. Culture change is the hardest part, but it's also the most important one. How do you know if the changes are working? Measure, but measure the right things. Track error rates, especially near misses, because near misses happen much more frequently than actual errors. So they give you early signals, okay? And then track staff reported obstacles and workarounds. If these are decreasing, your designs are improving. Measure time to complete tasks. Are workflows more efficient? Monitor staff satisfaction and burnout scores also. Are people feeling better supported in your organization or not? And track patient safety events. This is the ultimate measure, okay? Now monitor injuries, sick days, because these are often, these often decrease with better ergonomics and system design. Measure before you make the change, then measure after, because data improves, data drives improvement. Okay. Now, let's be honest. You are going to face resistance. Let me give you some common objections and how to respond to these particular resistances. If the resistance is like, we don't have time or money for this change, your response should be like, we don't have time or money not to do this. Each serious adverse event costs tens of thousands. Staff turnover costs thousands per person. Prevention is cheaper than reaction. Okay. And if they say our staff just needs more training, you say training helps, but design changes work better and last longer. You can train someone perfectly, but if the system sets them up to fail, they will eventually fail. So fix the system. If they resist with, we have always done it this way, question them back, asking as to, how's it working? Are you getting the outcomes you want or not? And then present the new evidence showing better ways. Then why wouldn't we use them? And if someone says all you're talking is just common sense, agree. Exactly. That's the whole point. Human factors engineering is about making systems make sense for the human beings using them. But common sense is not always the common practice, right? Keep on facing all these challenges. Resistance will come, but eventually you will overcome this. Okay. Now, let me give you a simple action plan template. For the first step, identify one high priority problem. Don't try to fix everything, just pick one. And in step two, analyze it using the SEEPS model. Look at all five elements and how they interact. And then in step three, engage with frontline staff because they have the knowledge which you don't have. Use it. And in the step four, brainstorm the solutions together. Multiple perspectives lead to better solutions. Okay. And in step five, test it on small scale, pilot in a single unit before rolling it out. And in sixth step, measure the results. Did it work? How do you know? And then finally, refine the design based on what you have learned and implement it in other areas. Start small, scale up later. That's how lasting change happens. Okay. Now, before finishing off, we are going to talk about few case studies. I just walk you through the successful case studies regarding human factors engineering. This is the first case study where we have already spoken about the PCA pump design. Here, the problem was the patient controlled analgesia pumps had confusing interfaces and staff frequently made programming errors. These errors led to adverse drug events and even to some deaths. Vincent and his team studied the problem. They found that the interface violated basic human factors principle. It was possible to make dangerous mistakes and not realize it until it's too late. So the intervention happened. User-centered redesign process. They involved clinicians. They simplified the interface. They added clear visual feedback. They created forcing functions that wouldn't let them make certain dangerous mistakes. And finally, the results were significant reduction in adverse drug events, faster and easier programming, higher user satisfaction, and most importantly, safer patient care. Coming to the second case study, this most of us know, wrong site surgery prevention. Here, we are talking about WHO surgical safety checklist. The problem was wrong site surgeries were happening, multiple system failures, complex workflows, no standardized verification process. And then WHO developed a simple 19-item checklist. Team briefings before surgery, mandatory timeout to verify patients, procedure and site marking protocols, team debriefing after the surgery. And the results were massive. Surgical deaths decreased by 47%. Complications decreased by 36, improved team communication, better safety culture. Simple checklist, massive impact. And the final third case study is medication room redesign. Here, the problem was frequent interruptions during medication preparation with poor lighting, lookalike medication stored near each other, cramped space. All the references for these are given below. Okay, the intervention they created was they created a dedicated preparation area with improved lighting, and they implemented color coding for separation of lookalike medications, and then they created physical space allowing for proper workflow, and as a result the medication error risk substantially reduced, the confidence of the nurses increased, there were fewer interruptions, faster preparations with fewer errors. Here the design changes worked better than training alone would have actually did. Finally, this is what we have already discussed regarding the hospital, the National Rehabilitation Hospital in Ireland. Here, the challenge was building a 120-bedded rehabilitation hospital to prevent staff injuries and maximize patient independence right from the start. This is a rehabilitation hospital, okay? So long-term care. The approach was to build full-scale mock-up rooms, 6 months of user testing, then iterative refinement based on feedback, got every input, every detail, right from the bathroom layout to equipment placement, everything. And the final outcome was the final design eliminated the injuries, enhanced patient independence. Patients could do more. That was a comfortable, efficient workspace for staff as well. So here the lesson was when we design it right from the start, the proactive human factors engineering is far, far cheaper and more effective than reactive fixes later on. So we are coming to the end of our session. Let me make sure you're living with essential messages. Here, the number one is to err is human, and that's okay. We all have biological limitations. That's not a moral failing. That's just being human. Understanding our limitations is the first step in designing around them. Okay. Now, number two, systems cause most errors, not people. When good people repeatedly make errors in a system, that's a systems problem and not a people problem. Fix the system first. Number three, good design prevents errors better than training alone. Education is important, but design changes are more robust and that lasts longer. Number four, you can make the difference starting tomorrow itself. You can't, you don't need to wait for organizational transformation. You can identify problems, advocate for changes, and implement improvements in your own area. Finally, the evidence is clear. Human factors engineering works and saves life. This isn't a theory, it's proven. Okay. So, what are you going to do early next week? Here are the 5 concrete actions. First action, observe your workflow in your area, watch, see the obstacles, see for shortcuts, and then ask your colleagues one simple question. What makes your work harder? Okay, listen to them. And third action, Identify a few things, suggest visual differentiation, talk to your pharmacy, right? For fourth action, assess the lighting in your medication area, see whether it's adequate or not. It's an easy fix, right? And then fifth action, share one human factors concept with your team. Maybe show them the Swiss cheese model that we have discussed, or talk about how fatigue affects performance. Start the conversation, because small changes actually accumulate to have a big impact later on. You don't have to solve everything, just do something, right? Now, if you want to learn more regarding human factors engineering, these are the tools, these are the organizations, the WHO patient safety program. And let me tell you, this human factors engineering at Ergonomics is included as one of the core objectives for WHO patient safety program charter for 2021 to 2030. Okay, so WHO side does have some good resources, and the Human Factors and Ergonomic Society has a few trainings and publications as well. And as usual, Institute of Healthcare Improvement has toolkits and courses regarding HFE. And you can also check for your national portals as well. When coming to the free tools, SIPS 101 simple free tools are available. Karayan et al. Is one of the authors, one of the teams. Karayan is one of the authors who have significantly contributed towards the SAPES 101 model. You can go through his research papers as well, and I'll try to actually give out the references of this particular session after this, if at all some of you are interested to go through, and then you can go through the WHO safety checklist also. And also I recommend you to look after the team steps resources also. They are available online. And my suggestion is keep learning. This field is constantly evolving, and we as we understand more about how to design safer systems and all, it will be easier and it will be safer for us to implement at our workplace as well. So my final thought, every time you identify a design flaw in your workplace, every time you suggest an improvement, every time you advocate for safer systems, every time you speak about something that doesn't make sense, you are practicing human factors engineering. You don't need a fancy title, you don't need an advanced degree. Okay, you just need to pay attention to how systems affect human performance and be willing to say, we can do this better. You're not just learning the boring sort of concept. You're trying to gain the practical tool which is aimed at making healthcare safer for both the patients and for yourself. Okay, and that matters. You matter. The work you do does matter. So thank you so much for your time and attention. I hope this session was valuable for you. I hope you'll be seeing your workplace a little differently now. And I hope you are feeling, what do you say, ready to make the changes for a better and safe place at your work. Okay. Now, I would like to hear from you the questions, whatever you have, or any sort of examples at your own workplace that come to your mind, or the challenges you might be facing. Anyway, let's discuss. I'm open for questions and the discussions.
Thanks a lot, Dr. Nadim, for your informative lecture. Very, very important topic, and very informative, and explanation, way of explanation was very great. If anyone has a question, you can open your mic.
Hello, good evening from Saudi Arabia. This is Muhammad Hashim, Quality Director of Jubail Health Network.
Well, good evening.
Thank you so much for your valuable actually presentation. I have just one question. How to balance between just culture and pay for performance? Just culture sometimes need an disciplinary action for employee if it's, for example, reckless behavior, and pay for performance also. It's about paying for those who are doing good job and no blaming also no punitive culture is how to balance between all of these three.
Right. So here, what I would like to say is, looking at the just culture, pay for performance, and non-punitive actions, I think there's no one way going forward for every incident or everything that happens around at our workplace. I personally believe there should be non-punitive sort of policy as far as the reporting any near misses and any incidents is concerned. Okay. As far as the pay for performance is concerned, obviously this is to encourage good things that we generally come across. And how do we balance the sort of punishment or what do you say for any sort of critical events? First, let us look at the incident that the particular employee was involved in. It might be because, what do you say? First thing, we should be thinking about the systems. Was there any fault within the system that this particular event has happened? In case if that's a system error, then obviously no good employee or no sort of, even if your best employee was present over there, that wouldn't have been avoided. That error would have happened. So here the fault lies with your system. So there's no point in punishing that particular employee, right? So and then in case if there was any person error, let's say the person error are also different types. In case if the error was because there were any sort of additional factors, though the mistake and error was from the staff side. If there were any other factors influencing that particular incident, then I would say let us not punish that particular employee. But in case if there was any sort of gross error or say gross malpractice or intentional sort of mistake from that particular employee, then in such instances, I personally would recommend to go for the punishment and the balancing things. But apart from that, most of the times I prefer non-punitive action for reporting and everything. Sometimes helping the employees out to overcome those particular incidents, not to repeat those mistakes and all, retraining them and all, apart from fixing the systems. And then paying for performance, encouraging good sort of employees for doing extraordinarily well, looking after everything. But in cases of sentinel events wherein the actual what do you say actual malpractice or actual error does lie intentionally with that particular employee, I would simply go for what do you say, the punishing the staff in that particular case. But that is usually referred usually reserved for the final thing. I don't generally take that up the first at the first place rather. I hope I was able to answer the question which you have asked. In case if not, then reframe it, please.
No, totally agree. Thank you so much. Thank you so much.
Thank you, Hashim.
Just an addition, I wanted to add that just culture differentiate between human error, at-risk behavior, and reckless behavior. Because in just culture, we are not saying that totally no blame culture. It is a balance between human accountability and system accountability. In just culture, we must differentiate about the mistake. Is that mistake is human error? If okay, so we have to make console with the person that was involved in that error. If it was at risky behavior, in that case, we must make coaching for the involved person to not do that at risk behavior again. If it was confirmed through James reason, five questions in James reason, if it is already confirmed that it is reckless behavior, in that case we must have blaming or punishment for the involved person.
Thank you for articulating that in a better way. That's the best answer.
Thank you for all.
Anyone have any question?
Good afternoon.
Good afternoon.
My name is Ibrahim. I'm a risk manager. Just I want some advice from you and from the team. How we can encourage like the leaders and the staff for the proactive risk or proactive incident prevention. Because really, if you can see, it's very difficult to convince them about the risk. Whatever we are doing, training session, informing them about the risk, what's the meaning of the risk. The idea still for the risk for them, there's incident happened. That time they are working as reactive. What advice you can help us to have as a proactive? Because it's very important to prevent the incident or to have system in place before it's happened.
Right. So how to encourage the staff for proactive risk management rather than for reactive ones. So he and also how to convince, including the leadership, what I assume. So when in case if you are going to implement certain things that are going to change the system, that are going to change the workflows and everything, obviously the resistance will be coming. And if at all it's a management, let me be very blunt. I am from the management as well, and most of the times the management or the leadership does listen to the language of the cost factor or the money factor in a way. Sometimes, most of the times, I believe. And if you can quantify the costs and benefits of that particular intervention, and if you can say that the proactive sort of risk management or the proactive implementation of this particular project does help us out mitigate the future losses in a way, like I'm talking about the cost of poor quality. If at all, yes, I do assume that the cost of implementing good quality is a fair amount, but definitely that's far lesser when we compare to reactive cost of poor quality. So for the leadership and for the management who are more towards the P&L sort of the budgeting and all the cost cutting factors and all, they do understand the language of quantification. You are supposed to put forward the benefits outweighing the costs. That's one way. And coming to the end user, look, my approach for my clinicians at my workplace, what I usually do is I take them the examples or the case studies or some sort of anecdotes wherein certain errors have happened that have led to the disasters or a sort of the sentinel events involving the patients and the healthcare staff. And I try to give them examples of why they happened, how they can be prevented, and why it is important that we act proactively. And once I put forward those arguments with my clinicians, they do generally understand why it's important to document certain things. I'm talking about the clinical documentation in the patient record, as well as WHO, the following of WHO surgical safety checklist. Let's take the same example of WHO safety checklist. That's in a way like to minimize the errors later on. That very much comes very much near to the risk management in a way. So here, what happens if we implement and what happens if we don't implement? Yes, that may be about 2 minutes of time or say 5 minutes of time that goes into implementing that particular step. But the benefit of implementing that checklist is it far outweighs the costs. The patient getting wrong side surgery gets minimized with implementation of the checklist. If the checklist is not implemented, then the patient may get the wrong side surgery. The patient may go to the court of law. The patient, there may be actual harm to the patient as well, and the patient may go to the court of law. And all this cost, again, I'm talking about the cost and benefit. When we talk about these terms, quantifying is very much important. Taking up the examples and the references is important for them to understand the impact what we are talking about, because most of the times they're all busy with their own processes and all. They might not be thinking in our terms, and for that very reason we are specialized in quality and risk management. We are there to remind them as well, right? So always try to give the perspective from the costs and benefits, the positives and negatives, and hopefully you say that most of the times does help. That's from my own experience as well.
Thank you, thank you. Really, because we need to have different way from what you are doing, especially when it's coming to budget and to have additional system or additional things. So if
Yes.
it's no incident that you are not, there maybe yeah, in some points you will not understand the future or the proactive how we are thinking about what we are expecting to happen. So that they said, yeah, usually they are thinking if no incident happened, why we need to pay money, why we need to يعني invest in these things. Thank you.
It's better to invest a small amount now to
Yeah.
proactively mitigate that risk rather than paying it big later on.
Yeah, this one
Yes,
is the
yes.
difficulty, how we can change the mind.
The
You
quantification,
you
and
you
real-time
you can
examples might help.
you
Okay,
can,
thank you.
doctor, you can use the principle of the cost of quality and the cost of poor quality.
Yes.
This is the best way to convince leadership for think proactively for risk management. Because if we explain that difference between cost of quality and the cost of poor quality, the cost of poor quality may be internal or external. If it reaches to external failure, we may lose all our business. If it reaches to the patient and reputation and the claim or and so on and so on, we may lose all our business. So it's better to pay proactively for quality initiative or risk management programs to prevent future occurrence of like that.
True.
Okay, thank you. Thank you for all. Anyone have any other discussion? It's very valuable discussion today. No other question? Okay. Thanks a lot, Dr. Nadeem, for today event. Really, it was very informative. دكتورة شيماء المايك معاكي.
Thank you,
Uh,
Dr. Nadeem, for such a great session. And a big thank you to everyone for joining us today. We hope you found it valuable. See you at our next event. Have a great evening.
Thank you. Thank you very much, Dr. Wissam, for this opportunity. And thanks, Dr. Mona, as well, for coordinating this event. Thank you, everyone, for participating. And in case if you have any sort of doubts and want to have discussion as well, I'm available in the group, and you can tag me and we can have discussions